Thank you, everybody. I'm glad to be with you guys today. As you sort of have seen, it's a bit of a potpourri that we're finishing up with today. Some topics that are of interest to many of us, with some interesting sort of notes as we go along the way. So we'll get started. So the first topic is ICH in special populations. So the overall goals here are to review some of the unique considerations in special populations and to identify the key considerations in those groups for how to optimally manage them in the setting of their acute injury and after in their recovery. And as a side note, I do talk quickly, so wave at me or something if I'm talking too quickly, but just let me know as we're going. So I'm going to start with the case here. So you have a 29-year-old male, a younger person who's brought in by ambulance after they found him wandering around outside. In the trauma bay, he was a bit hyperthermic with a temperature of 38.5. He was quite hypertensive, a little bit tachycardic, breathing a bit fast, but he was setting okay on room air. On your exam, he's quite agitated. He's moaning. He keeps saying over and over that his head hurts. When you finally get him to pay attention to you, he'll actually orient for you times two. And he opens his eyes to stimulation. When he does, this is what you see. So his pupils are a bit dilated there. He initially localizes briskly. He seems pretty upset about his headache, but when you finally get him to pay attention to you, he does follow commands. He's a little bit stronger on the right side than on the left side. So what are your next steps? So with any patient who comes in with an altered mental status, you really want to kind of circle back to your ABCs. You want to make sure they have good control of their airway. And as he's talking and interacting with you, you know that's okay, at least for the time being. Circulation in the trauma setting, we typically think about blood loss. In this case, his vitals are all the way on the top end. So he's got crazy high blood pressure, crazy high heart rate. So the things we want to pay closer attention to as we're evaluating this patient. So we want to work on stabilizing his vitals first. We want to get potentially an EKG, considering that his heart's probably under some stress from that hypertension and tachycardia. Probably want to send off some labs, in particular a urine drug screen, which would be quick and give you perhaps some helpful information. And then as kind of obvious for the topic of our conference today, you want to get some head imaging. So he's a little bit of focal on his neurological exam. He's weak on one side, keeps complaining of a headache. So lo and behold, turns out he does have an intracerebral hemorrhage. So you can see hyperdense material in the thalamic region extending toward the ventricles. So that's just to set the stage a bit for us here. And of note, his urine drug screen does come back positive for cocaine. So special populations, the two that we'll talk about today are ICH in the setting of illicit drug use, and then ICH in the setting of pregnancy. So two very different things, both in the younger age population. An interesting point with both of these is that the underlying mechanism is quite common to many of our other hypertensive, or other hemorrhages that we see, which tend to be hypertensive in nature, and so we'll get into that momentarily. Again, these are relatively small groups of patients in the overall big picture. So your classic hypertensive hemorrhage is an older gentleman with like bad cholesterol, hypertensive, all those things. And these are relatively small groups of patients compared to our common patients. And so they don't make much of an appearance in the guidelines, which can make management challenging at times. Same general principles apply, but there's certain unique considerations to keep in mind, and we'll go over a few of those. And then again, just for your reference, here's how the guidelines are presented. You have a class of recommendation and a level of evidence. The higher class tends to have better evidence supporting it, or if it's sort of a duh kind of recommendation, those are also often giving a higher level of evidence, and you'll sort of see this periodically. Again, less often in the current guidelines, just because it's smaller patient groups that are harder to study. Starting with the illicit drug use category. So of note, this is not all illicit drugs. This is specifically the drugs that are considered sympathomimetics. So they mimic the sympathetic nervous system, also known as stimulants or adrenergic agonists. The two that are of more commonly used and are of importance in this patient group is use of methamphetamines. And so methamphetamines work by both causing the increased release of neurotransmitters, and it keeps them from getting broken down properly. So not only do you have this, you have a sort of double whammy in a sense. There's more epinephrine and norepinephrine in the system because you're putting more in the system, but the drug also keeps it there for longer. In slight contrast is cocaine, which inhibits the reuptake. So the same neurotransmitters are put out by the neurons, but they stick around for longer. And that does have some implications for how long these drugs act in the human body. And so again, these are sympathomimetics, so they mimic the sympathetic nervous system. They sort of mimic that fight or flight response. And what happens in fight or fight? Your heart rate goes up, your blood pressure goes up, you start sweating, you can get agitated at the severe end of the spectrum. This is just some data from an older study in which both chronic cocaine users and intermittent cocaine users were administered the drug and showing some showing increases in both, I guess my pointer's not working, increases in both the heart rate and blood pressure, which decreased over time. At the very severe end of the spectrum, you can get seizures, rhabdomyolysis, and MI or hemorrhage, which is what we're talking about in the patient case today. In chronic users, there's some thought that a vasculopathy might develop over the time, and so the vessels just respond to this irritant compound that's in the bloodstream, and perhaps are more friable, more easy to break in the setting of a chronic use. Again, small patient populations, it's really hard to study this, but that's the current thought. There's some variance in the data on the incidence and risk of hemorrhage in this particular population. There's many case reports from the 1970s on forward. Mostly retrospective studies. They tend to be autopsy-based studies in those earlier years, looking to see for any correlations between the presence of a non-traumatic head bleed and the use of, or the presence of a toxic substance in the urine or in the blood. And you can see the associations listed there. Some of the studies more recently suggest that there's a stronger risk with amphetamines or methamphetamine, and again, that's sort of because of the dual mechanism in which there's more neurotransmitters deposited and less taken up. And then a most recent study published out of Australia, over 90% of meth users, they found that strokes in that population were hemorrhagic in nature, which is the complete opposite of what we see in the general stroke population. There is a review a couple years ago that takes all of these into consideration and tries to develop an overarching risk profile. So they found that amphetamines were the cause in about 10% of all hemorrhagic strokes in the population they studied, and that conversely, 80% of methamphetamine user-related strokes were hemorrhagic in nature. So this all makes sense based on the mechanism of what the drugs are doing in the body. So when this patient rolls into your ED, how do you know what the cause of their hemorrhage is? In a lot of cases, the history is key, knowing that history of recent drug use or suspicion of recent drug use. And one of the recommendations that's like sort of peripherally pertinent here is to get a good history, to get a good physical, to make sure you're very thorough in your assessment of the patient, things that kind of make sense. And so do specifically note in the types of labs to include a toxicology screen, which is important here, and then again, history of substance abuse, specifically focusing on those sympathomimetic agents. It's really important to maintain a high index of suspicion. So young people typically don't get strokes. So in most of those patients, something weird is going on, both on the ischemic side and on the hemorrhagic side. So you really have to keep an open mind and consider all sorts of different possibilities explaining their hemorrhage. In some people, it's a vascular malformation, and some people, it's perhaps would be an illicit substance that was recently used. There's some studies looking to see whether the pattern of the bleed is suggestive, but there's really no conclusive evidence. Some suggest lobar, some suggest deep hemorrhages. It's not really consistent between studies, unfortunately. So again, history is really going to be important in working up these patients. Again, the hemorrhages can look like pretty much anything. They can look like your typical deep hypertensive hemorrhages. They can look like a lobar hemorrhage. They may or may not involve intraventricular extension. So the imaging is not super useful in eliciting the etiology of these lesions. So in the acute phase, what do? Same general principles as any ICH that's not associated with substance abuse. So focus on your ABCs. Most of the time, these patients will not be obtunded. They'll be sort of the opposite end of the spectrum, quite agitated. If it gets to the point where they might be a danger to themselves or others, it might be a consideration for helping to control their airway in a sense. And again, the circulation is sort of on the other end of the spectrum. You want to make sure that they're not going to hurt their hearts or their brains, further damage their brains from that out of control blood pressure. Again, just as you heard in all of these bleeds, blood pressure control is absolutely key. I won't go into this in detail, as I know you've already had a talk on this already, but that's a very of paramount importance in helping these patients. In the acute phase, if you're looking for a continuous IV agent, you can use nicardipine or clofidipine. That's more in the ED or ICU setting. Hydralazine and labetalol, IV push, are good agents as well. And those tend to be sort of built into the protocols in most hospitals. There's this phenomenon known as unopposed alpha activity, and it was thought to be important in the setting of these sympathomimetic agents, in which it was recommended you do not use beta blockers. And the thought there is that the norepinephrine, epinephrine, that's elevated in the setting of this substance use, if you only block the beta receptors, you still have the drug binding to the alpha receptors that are left over, and those will cause further vasoconstriction, make that blood pressure shoot right up, and potentially worsen the hemorrhage. There's more recent data looking at large groups of patients that suggest this is sort of a theoretical phenomenon, and maybe it doesn't bear out in clinical practice. Lucky for us, the beta blocker, quote, beta blocker that we use is actually a mixed alpha beta blocker. So labetalol hits both receptors, and so that theoretical risk is not as strongly associated or at all with this agent, which is why you commonly see it used safely. Rarely, you'll see people thinking about nitroprusside or nitroglycerin for blood pressure management. In this setting, it's avoided because it has an association with elevating the intracranial pressure, which would not be a good thing in patients who are already having a problem with that in the setting of their hemorrhage. And then anything else that needs to be done should be done just like any other hypertensive bleed. If they start to seize, control the seizures. If their ICPs are starting to go up, consider neurosurgical consultation to get the bone off or the clot taken out, if that would be appropriate for the patient. If they're on warfarin for mechanical valve or something of that nature, reverse the warfarin. All the same things you would do for any other hypertensive or any other ICH patient. In the subacute phase, you want to manage their toxicity from the drug that they've taken. In this case, benzodiazepines are often central use. It helps with the agitation. If they tend to have predominant hallucinations as their symptomatology, you can consider antipsychotics. And younger people tend to tolerate those a bit better than older people. They still have a number of side effects that you'd probably best to avoid if you can. The role for decontamination is very limited. So by the time they hit the ED, the drug is already in their system. Giving them activated charcoal or some other agent to try clearing it from their stomach will not be helpful, so it's not indicated. And then again, once the drug is in the body, it's cleared fairly quickly. Cocaine tends to last not as long as methamphetamine. The problem with methamphetamine is it gets metabolized into other compounds that have similar effects. And so blood pressure control in a monitored setting is perhaps a bit more important in the group of patients that have taken that substance compared to cocaine. If the bleed looks kind of odd in appearance, you consider vascular imaging. You do have patients who have a vascular lesion like a malformation or an aneurysm who also happen to use illicit substances, which puts them at increased risk of rupture of that. The pattern of the bleed might be suggestive of that, but if there's anything odd appearing about their scan, you can consider CTA or something of that nature as well. That's obviously after you've gotten them stabilized. In the long term, you have to work on substance abuse management if this is a chronic problem for the patient. And this is also, in a sense, reflected in the guidelines through lifestyle modification. They actually spell out positive effects of multimodal secondary stroke prevention. If they're using recreational drugs, it would be good to counsel them to stop doing so. So it's kind of built into this recommendation as well. Any questions on that group of patients? So same general principles, low index of suspicion for something weird going on in a young person with a brain bleed. All right, our second special group is the setting of pregnancy. And so impact of pregnancy on ICH. So stroke in general in pregnancy is quite rare. Women who are pregnant tend to be on the younger, healthier side. Hemorrhagic stroke on top of that is even rarer at 6 to 10 per 100,000. When you see ICH in this patient population, it's also associated with hypertension. So common across all of these patient groups in many cases. Specifically here, we're talking about preeclampsia or eclampsia. One of the underlying definitions of this diagnosis includes hypertension. And there are studies that show that up to 1/3 of patients, of pregnant patients with ICH have a diagnosis of preeclampsia as well. And unfortunately, preeclampsia confers up to 9-fold, some studies 10-fold risk of ICH in that setting, which is why it's important for this disease to be closely monitored and managed when able. The other one that's closely associated with this is hemolysis, elevated liver enzymes, and low platelets, or HELLP syndrome. Some people consider this to be a more severe version of preeclampsia, and some people consider it to be a separate diagnosis in itself. Up to 40% of patients with this diagnosis, unfortunately, also have an ICH. The problem here is not only the hypertension, but the thrombocytopenia and other factors that make it more difficult for them to hemostase and sort of stop that bleed from expanding. Again, same primary mechanism. It's really the hypertension that's driving the pathology in these patients as well. The unique thing in the patients with HELP syndrome is the other things going on, the thrombocytopenia. A patient with a history of preeclampsia will times be put on aspirin as a prophylaxis to have that recur with a second pregnancy. And so that would be a consideration, again, in the management. If they're on an antiplatelet, think about what you might have to do to address that in the acute setting. The highest risk for this is during the third trimester. In a sense, I sort of conceptualize it as their brains have been seeing this elevated blood pressure through a long duration of pregnancy, and so the risk is going to be highest toward the end of that. I don't know if there's quite evidence to support that, but that's how I sort of remember the timing of this. Oddly, it can also rise in the postpartum period. So once the baby's born, they're not out of the window if they have a diagnosis of preeclampsia. You have to keep watching them for a little bit longer. The highest rates in studies have been about within a week of delivery. And so it's important in someone with a diagnosis of preeclampsia for them to be checked in on shortly after birth to make sure they're still doing okay. Unfortunately, it's quite morbid. So about 20% of patients with ICH during pregnancy do end up dying, and up to 80-fold increased risk of mortality if this were to occur. Part of that is the pathology, part of it is the ways in which the blood coagulation cascade is altered in pregnancy and things related to that. So it's quite serious. How do you know? History is going to be fairly clear. Your patient's pregnant. They come in with perhaps a severe headache. They come in with perhaps focal neurological deficits. So if they are pregnant, have a diagnosis of preeclampsia and a bad headache, or they're focal, that should raise a lot of red flags to take a close look at what's going on. Sometimes the concern for radiation exposure to the baby delays their diagnosis, and so many groups will say the exposure to the fetus from a single head CT is relatively low in the overall scheme of things. Not only is it sort of physically further away from where the baby's at, the uterus can be shielded, and it's really important to make sure mom's doing okay, because if mom doesn't do well, the baby's not going to do well. In the acute phase, same kinds of things. So ABCs, make sure the airway is controlled, circulation is doing well. And the other factor in the acute phase, again, is blood pressure control, just like any hypertensive hemorrhage. The unique thing in this setting is thinking about what drugs might be toxic to the fetus. And luckily for us, the ones that we use commonly are not. So hydralazine is safe, labetalol is safe, nifedipine, nicardipine are both safe for the fetus. The other weird one that you learn as being safe in pregnancy is alpha-methyl-dopa. I've never seen that used in a hypertensive bleed patient in any setting. I think it just tends not to work as well. But the agents you see commonly are also safe for mom and baby in managing that blood pressure. You need to reimage as it's indicated. So if mom's doing kind of okay and all of a sudden gets very somnolent, if she starts to develop new weakness, you need to rescan her and see what's going on in her head. And then just as with our patients who use substances, a young woman might also have an aneurysm. She might also have a malformation, a vascular malformation that could merit further treatment. Again, that tends to be addressed sort of after everything's calmed down and sort of based on the size of the lesion, how it's affecting the neurological exam and things of that nature. If she's on aspirin, take that into consideration. Most guidelines don't recommend giving platelets to reverse aspirin, but you might see some places doing that. If she's seizing, control the seizures. If her ICPs are high, you might have to consider a cranial or other surgical procedure. In the subacute phase, get the rest of the team on board. So as soon as mom comes into the hospital, contact and consult your OB team, because in a sense you sort of have two patients, and the baby is also at increased risk of mortality in this setting for reasons that we don't fully understand. Could be related to the hypertension, could be related to mom's sympathetic response to the brain bleed. But the baby, the fetus is also at a 5 increased risk of mortality. In the setting of preeclampsia and HELLP syndrome, this is more of a pregnancy side of things, but the cure for those is to deliver the baby. And so if that's safe, that might be something that's considered to help with ongoing blood pressure management, ongoing platelet dysfunction. And so this is very much a multidisciplinary team conversation between the patient managing mom and her hemorrhage and the patient helping with mom and her baby. In the long term, lifestyle modification if needed. And so just like any other patient with an ICH, if they had underlying hypertension to start, manage that afterward. If they had diabetes to start, manage that afterward. A unique consideration in this setting is thinking about what medications are going to be safe in the setting of lactation and breastfeeding. Most of the medications we use are, but there's some nuances there that you can look up if you ever have to run into this if you're managing one of these patients. And all of the other things that were sort of known to be associated with hypertensive hemorrhages or other ICHs, those need to be monitored in the long term as well to reduce mom's risk in the future. The other thing that's more of on the OB side is that if mom has a diagnosis of preeclampsia, she's more likely to get it again in a second or third pregnancy. And so that's something to be considered for families that are considering to grow in the future. So big picture, taken all together, so hypertension is a common mechanism in all of these patients, and it's managed in a very similar way. There's some nuances with how you want to manage the blood pressure, but luckily our common medications are safe and effective in both populations. And then in the setting of the pregnant patient, in a sense, you have a second patient you're taking care of. And so taking care of mom helps you take care of baby. And sometimes delivering baby is the way that you treat the underlying HELLP syndrome or preeclampsia that mom has. And that will help sort of the care of both patients. Any questions on any of that content? I know it's a bit of a whirlwind. I know I talked fast. I know it's a lot. So feel free to speak up.
I had a quick question. So for the OB patient, let's say they are in eclampsia, do we have any study that suggests which ICU they would be having better outcome? Is it neuro they should stay in, or because there's always a debate. I get these patients, I am covering ICU, and they're like, oh no, we cannot deal with this.
That's a great question. I don't know data. I know in the hospital that I trained in, the patients were managed in the neuro ICU, and then OB was very heavily involved in their care. It's quite rare overall, but it was very much an ongoing collaborative discussion as we managed the patient. I don't know that there's any data. I'm not aware of any, but anyone who is, feel free to speak up, please. Thank you. So I'll switch over to my second topic, the other half of the potpourri that has been mentioned a couple of times. So the role of lipids and statins in the setting of ICH. So there's some controversy. Do they keep their statins? Do they stop their statins? If they have all these other risk factors and they have a bleed, do you start a statin anew? I'm going to tell you ahead of time, there's not a great answer, as you've sort of heard already, but we'll kind of go through some of the details. So we're going to look at the impact of statin use on hemorrhagic stroke risk and recurrence, kind of in big picture terms. We're going to think about why these interactions might occur, and then ultimately what implications this may have for our treatment recommendations. So it's complicated, as has kind of been alluded to. So the first issue is it the statins themselves that are affecting ICH and its risk, or is it what the statins are doing to the lipids, and are the lipids affecting ICH? The second issue is, when is this interaction occurring? Is it patients who have been on statins for a long time or have a history of high lipids or low lipids, high cholesterol, low cholesterol? And is it thus related to risk factors for developing an ICH? Is it during the ICH? Does it have an effect on the ongoing inflammatory processes? Is the brain responding to that hemorrhage? And again, is it the lipids doing it, or is it the statins that are affecting it? Or is it after the ICH and thus affected by both how the brain repairs and responds to that injury? And again, sort of the risk factors come back in there as well. So it's pretty complicated. So big picture things, how ICH causes trouble. Obviously the main problem is you have an acute expanding mass lesion that's pushing the brain and causing elevated intracranial pressure. The whole secondary injury is that there's a whole ongoing inflammatory cascade. That's sort of the secondary injury, leading to edema, leading to free radical production. And the problem is that as iron breaks down, it releases electrons and other molecules that interact with lipids and cell membranes, and that sort of propagates the inflammatory process. And so that's, in a very general sense, how the lipids are involved in this, and then statins will impact both lipid levels, the types of lipids that are present, and also lipid function in general. So it's a bit of where that ties in here. There's lots of different people looking at lots of different pieces of that puzzle, and there's not really a great overarching, yes, positive impact, no negative impact. So both the injury leads to local tissue damage, the blood breakdown products, as I mentioned, which tends to propagate more of the free radical production, and it kind of goes from there. In terms of the early studies that looked at lipids, so there are a number of them, and it was quite odd because people started looking at ischemic stroke first. Okay, we know this is a bad problem. A lot of people have ischemic strokes. What factors can we associate with those to sort of modify and try and prevent strokes from happening? As people started looking at the hemorrhagic stroke side of things, it was all the opposite of what we saw for ischemic strokes. So increased lipid levels seem to be associated with a lower risk of brain bleeds, particularly ICH, and then higher cholesterol levels, low cholesterol levels led to a higher risk, and then higher cholesterol levels, which put you increased risk of ischemic stroke, were actually found to be associated with a lower risk of hemorrhagic stroke. And so that was kind of the interesting early findings, just looking at large groups of patients. And then the Sparkle trial came along, which was mentioned a moment ago. You can see the title of it there. This is actually a trial done in the setting of all stroke patients, but again, ischemic stroke being more common, that was the main proportion of the study population. So it was a study looking at whether starting someone on a statin after a stroke of any kind, whether that would change their outcomes. This included ICH patients, but again, as a less common pathology, it was only 2% of the population in the Sparkle trial. These patients got atorvastatin 80 milligrams daily, which is a pretty good dose. And they found that this reduced stroke recurrence at a median follow-up of 5 years by about 2%. It doesn't sound like a lot, but stroke is very common. Ischemic stroke is very common. And so there's a lot of people that were impacted by this. So based on this, in a later trial that was called the Treat Stroke to Target trial, the AHA updated their 2021 guidelines to recommend the initiation of atorvastatin 80 milligrams daily in patients with ischemic stroke. So this is in the ischemic stroke guidelines. And these same authors that did the SPARKLE trial went back and looked at the different subgroups within the SPARKLE trial. So they looked at the ischemic versus hemorrhagic strokes initially, and they found that there were different outcomes. And you can see these are all strokes. The blue line is ischemic, there's more of them, higher lines. The red ones are hemorrhagic, lower lines. And then you can see that the dashed lines are the patients who did not get a statin. The solid lines are patients who did get a statin. You can see on the top two blue lines that ischemic strokes, there were less of them in patients on a statin. And the red lines, patients who got a statin, there were more of them in those who got a statin, of the hemorrhagic strokes. We looked both at non-fatal and fatal strokes. Not much of a difference in the fatal group, but in the non-fatal group, you can see that the lines are splitting as well. And the ischemic patients did better on a statin, hemorrhagic patients that increased their risk of recurrence, which is kind of scary to think about because we were doing this for a lot of people. Another trial looked at all stroke subtypes, seeing if there was something weird about how the small strokes fit in versus the large vessel versus small vessel. And you can see that all of the ischemic subtypes are all on the left of that line. All of the hemorrhagic subtypes are all on the right of that line. And even though none of those lines are actually completely to the side of one, so if it crosses one, there's statistically no difference. But you can see pretty clearly that there's definitely a trend there for the hemorrhagic patients all falling on the more of a risk with the statin side of the line. And so in the aftermath, a lot of people tried to look at this in a lot of different ways. They dissected multiple retrospective studies trying to figure out exactly what was going on, since these results are somewhat counterintuitive. You'd think lowering someone's lipids would probably be good for their stroke risk. So there's some studies that found no association. There's some studies that suggest it depends on the statin type. So statins that were more lipophilic or sort of fat-loving that could get into the brain easier. Maybe those are the ones that had this increased risk. And then there are some studies that used a bit more nuanced statistics that suggested that the statins might actually be beneficial in the long run. So it's led to quite a lot of consternation and not really clear guidelines about what we should do for these patients. So now what do we do? So the follow-up to here is called the Saturn trial. I'm not quite sure how they came up with that acronym based on the words in the study, but the Saturn trial is currently enrolling. This is a prospective trial, so these are patients that we look forward at and treat on an ongoing basis and then look back at how they did, as opposed to digging up a whole bunch of patients from a database and looking backwards and trying to make associations. These are patients with spontaneous lobar ICH who are already on a statin, and they're randomized to either continue it at the same dose, the exact drug that they were on, or just stop it entirely. And you'll hear people talk about this as a pragmatic trial, sort of purposeful, sort of realistic. We're not giving them a different drug, we're not changing the dose of the drug, we're just putting them back on the exact same drug or taking them off. And so it's very much kind of real world applicable in a sense. The primary outcome is time to recurrent to ICH, which is sort of the feared complication with restarting a statin in these patients. The primary safety outcome is ischemic MACE. And normally you see MACE as major adverse cardiac events, but they throw in cerebrovascular here because that's what we care about. Are we causing these patients more ischemic strokes by taking them off their statin versus keeping them on? So the study's ongoing. I'm not sure if our local hospitals are enrolled. The hospital I came from was one of the trial participants. The expected date to end is next December, so maybe we'll have some information by then. The nuance to note here is that they're all lobar patients, which is not necessarily, it's a good half or less of the population we treat. So even with these data, we still really won't know on a data-driven basis what to do with our hypertensive patients. But at least be something better than the retrospective trials that we have. So while we're waiting, what do we do? What do we do with what we know about what's going on here? So there's been, again, a number of more trials in different populations, making different comparisons, trying to figure out exactly what the relationship is and if it's more nuanced, which it probably is. There's a Danish registry study looking at location and statin use. They found a lower risk of ICH, and the risk was actually decreased with a longer duration of treatment. There's an Italian study from last year looking at statin intensity, and they found no effect whatsoever about anything they looked at. There's a biobank study from the UK looking at LDL cholesterol specifically, and they found that lower levels were associated with higher rates of recurrent ICH, but that the statins had no effect on any of it. The statins were just not associated. And there was another recent study, and this network meta-analysis is kind of a cool technique where they pull lots of different studies, kind of blend the patients together in a sense, and use that to get a year from a bigger population. They found no association of statins on ICH, but they found that atorvastatin or atorvastatin specifically had a low risk of death. And again, the challenging thing here is it the drugs themselves? Is it something else that the drugs are doing? It's hard to really tease that out with these registry studies. And so basically the AHA is, good luck. It's like, what are we going to do? As you guys saw already, so the recommendations in the AHA guidelines are In patients with spontaneous ICH and a reason to be on statins, the risks and benefits on outcomes and recurrence are uncertain. We don't know. And unfortunately, that's what the data is at right now. We just don't know. And so again, that's a weak recommendation. It's a non-randomized level of evidence, because that's just what we have at this point. We're working on getting some better data, but this is what we have to work with for the time being. So you really need to consider the whole picture, as was mentioned in the last talk. You really need to think about what other comorbidities the patient has, have an informed discussion. This may increase your risk of having another bleed, but you're at really high risk of, with your diabetes and your hypertension, you're really high risk of another stroke of ischemic type or other things that are going on. So you have to consider the whole picture. This group, Shamanish, published a decently helpful kind of flow diagram here in 2022 that helps to provide a bit more guidance as opposed to we don't know. So they're saying if they have diabetes and symptomatic atherosclerotic disease, you kind of go to that left side of the screen. If they don't, you go to the right side of the screen. It kind of parses it out to potentially restart their statin, stop it altogether, or use a different lipid-lowering therapy. The challenge with that is some of those haven't been studied in this population, so we don't know if there's an association. So it kind of circles back to, is it the lipids that are the problem, or is it the statin that's the problem? But this provides at least some guidance to work with. When I was looking up some data for the study, our European colleagues actually have a bit more of a definitive statement, which I thought was kind of interesting. They acknowledge that statins do lots of different things. They might have pro-fibrinolytic or anti-aggregating properties, and so it keeps the blood from clotting and sort of keeping that hemorrhage from expanding, which would be a pro-ICH effect. But they're also known to reduce inflammation, oxidative stress, and if the plaque is in a vessel, they make that plaque more stable, which is part of how it protects against ischemic stroke. And so they could reduce your susceptibility from hemorrhage. And so they go on to actually make a definitive recommendation. They say in patients with ICH who are taking statins, you should not stop them suddenly because there's worry that you have a rebound pro-inflammatory state. If you're going to stop it, you should probably wait until they've recovered from their acute illness, and that's in the setting of lobar ICH. In patients who are not on a statin already and have an ICH, you should not give them a statin unless they're clearly indicated if they're at very high risk of ischemic stroke. So just kind of an interesting approach to this. I think they have similarly limited data, but the people in their overseeing body felt strongly enough that they actually kind of made a more definitive recommendation here. So taking this all together, the risk factors for incident and recurrent ICH are probably more complex. The mechanism of secondary injury and that pro-inflammatory cascade are probably more complex than we thought. The role of lipids and statins are definitely more complex than we thought. We really don't know what's going on in a lot of cases. We have active trials that are ongoing, and for now, it's one piece of a multifaceted discussion. So you really have to sit down, look at their other risk factors, look at their family history, their personal history, other medications that they're on, and things of that nature, and really have a patient-centered and as thorough of a discussion as you can. And these are all references for all my talks, I guess, but that's it. Happy to take any questions.
Thank you so much. Looks like Katie's headed to the microphone.
Thank you. Yeah, I was just wondering if you're able to speak at all, if there's a risk of the LDL being too low being on statins and in relation to ICH, and if there's a threshold that you really look at there.
That's a great question. I know some have looked at that. I honestly don't remember what the cutoff was, but there's a couple of studies that have tried to split it into like less than 100 over 100, less than 80 over 80. And I think right now some of those studies suggest that lower is worse. I don't know that anyone's really suggested a cutoff to target for the therapy. Feel free to correct me if anyone knows better than I do.
I think 40 is the cutoff.
40 is the cutoff?
In the cardiovascular studies, they saw 40 and less than 40 increases the risk.
Thank you. So less than 40 increases the risk.
Hi, I just have to tell you, I have an answer for your naming clinical trials. So with these, I was a sub-investigator on Sparkle, and it was a contest. They got all the investigators, and they took suggestions on what to name the study. So,
Good. Thank you.
I guess my question is very, very general. But we're seeing in the world of stroke, certainly in the last 15 years, so many trials that drive our treatment and management decisions at the bedside. If or when do we think it's time to move to a living guideline document? Because I just did a presentation last week to our region about and I know this is a little off topic, but it matters, about the use of thrombolysis outside of our traditional window. We don't practice like that anymore. But the guidelines tell us X, Y, and Z, but we're practicing totally differently. And I think some of what you're talking about, we're modifying our practice that does not align with clinical practice guidelines. Correct. And so is there going to be a conversation about our guidelines being a living document?
That is an excellent question. I cannot speak on the behalf of the AHA related to that. I know in one of the other hats I wear in neurosurgery, our neurotrauma guidelines, they have switched to that because there's new data all the time that suggests doing things a little bit differently than in the published, quote, evidence-based guidelines. That does have its pros and its cons. Some of the recommendations in one of our groups is sort of expert consensus. It's like the Delphi approach, an expert consensus. So they'll take the evidence, they get a whole bunch of people together who have been practicing it for 30 years and are on top of the literature and say, this is what the data said, this is how we practice and what we've seen to work in our patients, and we all agree. But again, you have to go back sometimes and say, well, there's no data, but maybe that's okay. I'm not sure about the AHA and their transition to something of that nature. But that's a very important point to make, is there's literature coming out all the time, and it's hard to keep up with it all as an individual practitioner. And so that's the purpose of conferences like these, where we can share some of that. That's the purpose of having colleagues halfway across the country, around the world. You can call and ask what they're doing to manage a pathology. But circling back to the guidelines, it's outside my scope of being able to speak, but that's a great, wonderful point.